So it's been a great afternoon so far, and we've got another great session planned for you now. So I'll introduce our two speakers. So our first speaker is Dr. Vikal Krukedi, who is a hematologist at University Health Network, Princess Margaret Hospital. And our second speaker, who is joining us remotely, virtually by Zoom, is Dr. Raymond Comenzo, who is also a hematologist and really one of the pioneers in the field as well. So we're very fortunate to have him from Tufts University in Boston. But we'll start off with Dr. Krukedi. So thank you very much for being here and looking forward to your talk. We're having key issues in the diagnosis and management of AL amyloidosis.
Thank you. So I'm going to start focusing on the diagnosis of light chain amyloidosis. And today, I'm really representing my role at the American Society of Hematology. I was the clinical chair for the diagnosis guidelines for light chain amyloidosis. This was about 2 years of robust work. So 22,000 articles later, strong methodology team, at least 20 clinicians with all walks of life. So it was community and academic hematologists, cardiologists, nephrologists, neurologists, internal medicine, laboratory medicine, pathology as well. And we had patient partners participate as well. It's a very standardized process for developing systemic reviews, asking particular questions. So we're going to focus on some of the learnings. I'll apologize that I'm not able to share the slides at this point. The paper is right now under a review process, so it's embargoed, but it should get launched within the next few months. Part of our work, which we'll talk about first, has already been accepted and should be out in Blood Advances soon. So I have no disclosures. And our two areas to focus on is what did the panel or the guidelines look at as it relates to two large areas: early clinical suspicion of amyloidosis and timely and effective diagnosis of light chain amyloidosis. That was the overarching theme of the guidelines. That's how the decisions were made. The focus of the audience for the guidelines are not just academic physicians and experts in amyloidosis. This request came through the society, through our community hematologists, saying, we don't see this every day. We're not experts in amyloidosis. We see it infrequently. We need to start the process, and we need to make sure that we do the best for these patients as possible. So the target audience and the guideline recommendations are in that vein. So if we look at the diagnostic journey, and many people talked about this today, for patients with light chain amyloidosis, they have presence of symptoms. Often they can be very vague symptoms for months to years, even up to a 3-year duration before a diagnosis of light chain amyloidosis is made. And it's sad to hear from Vaishali that even when a hematologist is following them, we have the same issues as well. So we also know that there are many different specialists before a diagnosis is confirmed, and we know that such delays have a negative impact on outcomes. So one of the work that we did, and this was early in our deliberations, the patient partner said, you know what, I'm really not interested in the final guidelines. I really think you guys should be raising awareness for amyloidosis because that's the most important thing, from the learner to all of the disciplines. What can you do as part of this guideline to do that? So we did. We asked the question of when should clinicians even suspect systemic light chain amyloidosis as a differential? And we did a scoping review, which is a thematic analysis, looking at what's known from the existing literature about signs and symptoms of different type of systemic amyloidoses. And we focused on light chain, but did a compare and contrast with wild type ATTR and mutant ATTR, because those would cover a large amount of amyloidoses. And this is work done by Dr. Giselle Cook and Hira Sheikh, and it's been accepted for publication, Blood Advances, hopefully in the next 2 months. We think this is a great article to share around for everyone to see. So let's look at our concepts around our models of care. So this is about 117 articles met the inclusion criteria. This is a pooled analysis of 25,000 patients. And if we look at things, majority of the literature here is retrospective in nature, some perspective. What's interesting in almost all of the articles, actually all of the articles, they're coming from academic centers. So that already tells you one part around the model of care is that we in the academic centers need to provide that support and multidisciplinary care for our patients. So that's one call to action to consider. If we look at the subspecialties, you'll see here, this looks at the number of patients with amyloidosis, the percentage, and the number of studies. 46 studies, or 78% of the patients before a diagnosis of amyloid is made, have seen multiple different physicians from primary care to all of the subspecialists listed. But to call out to the cardiologists, they're often the first to see either cardiology or cardiology with one other discipline. An organ involved as per symptoms at presentation, large portion of the time for light chain amyloidosis is a cardiac presentation. So the hematologist is often the last one to get involved. And we're about 2% that are first seeing these patients with amyloidosis. So I think that's another sort of call to action is our accountability at hematologists to raise awareness. And one of the guidelines, which I'm not going to focus on today, is the appropriate ordering of immunological assays, because that can be challenging for people who don't do this every single day. So we do want serum protein electrophoresis, serum immunofixation, free light chain assay with ratios, and we want a urine with immunofixation as well. Now the urines we know our patients don't like doing. They don't like taking the big orange bottle to take and do it. It's very cumbersome, and often it's one that's missed. If you do all three of those and any one of them are positive, you raise the awareness that this person could have amyloidosis, and you have to rule it out in that scenario in the right clinical context, obviously. And so for the 24-hour urine, our recommendation was majority of the literature is for 24-hour urine collection, but if you have validated concentration of urine early morning greater than 100 cc's, and your lab has validated that, in some centers they have validated, that is acceptable for urine immunofixation. It will not give you a 24-hour urine protein, which is a limitation, but that may be a good screening for a lot of our subspecialties that may not have those bottles in their clinic and can't get them to the patients easily. So this is really the presentation of what we learned. So what are the early symptoms and physical exam findings between the various types of amyloid? This is a very small slide for you to have a look at. It gives a comment on the median frequency, the range, and the number of patients affected. But let's do this in a more effective model. These are the heat maps. So if we look at the earliest symptoms, to my eye, they are separating out. So this is an important part. I think this would be a great slide for a learner to think about as well. You'll see they separate out. At the bottom is a key, which says the percentage of patients that are having these sort of findings. So if we go by shortness of breath alone for the earliest symptoms between the three common types of amyloid that affect the heart, we're not going to be able to distinguish there. Edema and volume overload seems to be more prevalent with wild type and variant ETTR than AL in terms of early symptoms. Neuropathy, you're going to see with the variant and less likely to see in the other two. Carpal tunnel is with the wild type, and the ones that you should ask for is fatigue and weight loss for the AL, because those may be early symptoms that we see. If we talk about the patient's most frequent complaints, shortness of breath is there, but autonomic symptoms we see most prevalent in AL patients, and then sensory loss and paresthesia in the variant. And you can see that painful neuropathy is not seen in the other two as the most frequent symptom. It is not a common symptom in light chain amyloidosis. So that's another part of the history that may help you understand what you're dealing with. And then the overlooked or ignored symptom bucket here, the weight loss, the abdominal pain, the early satiety is pointing towards an AL scenario. So again, an important part of the history. And then on the right-hand side, you can see the erectile dysfunction, altered bowel habit, urinary incontinence, more in the variant ETTR. So same thing if we look at the heat map for physical exam findings here. It again separates out. The grid is on the right-hand side with the percentage of these 25,000 patients who presented with this, but heart failure signs and symptoms may really not distinguish you. Hypertension was seen in wild-type ATTR and not in the other two scenarios. Orthostatic vital signs was more prevalent in the variant. Evidence of peripheral neuropathy was more prevalent in the variant. And then atrial fibrillation was more in the wild type with the carpal tunnel on exam as well. So I thought this was a great body of work. The table, when you'll see it, has been presented in a way, when the article comes out, from every discipline to think of. So what's someone coming to a neurologist with, to the nephrologist, to the cardiologist, et cetera, and what are the most common symptoms that you'll be seeing in that scenario. And as other people mentioned, Vaishali mentioned as well, that this is a great use for an AI tool to help people in clinic. So that's where we're hoping to take this next. So I'm going to move towards the diagnosis of light chain amyloidosis, and obviously nothing can be understated about taking a full history, physical exam, and doing all the right laboratory investigation. Our focus today is going to be on obtaining tissue and confirming a tissue diagnosis of light chain amyloidosis, because that is mandatory. So manifestations of amyloidosis, you can see on this body map here, there's no shortage of manifestation of amyloidosis. And some patients have some may have many of these, particularly in a multi-system perspective. So expectation for us as clinicians, no matter what discipline we're coming from, we think in light chain that it is more prevalent to have a multi-system presentation or more than one organ to make sure we're taking a full history and doing a full physical exam. I know probably other than the neurologist, most of the rest of us like to skip our neurological exam when we're seeing patients. Also, the clinical presentation is helpful, but it's not sufficient in subtyping what type of amyloid that you're doing here. Cardiac can affect many types of amyloid, renal as well. Yes, there's a preponderance towards the number of organs being involved being more in light chain amyloidosis than the others, but these more older ways in which we try to do things is not adequate at today's day and time. So you need to do a tissue diagnosis, and the question that comes to every clinician's mind is, I'm going to put two questions here actually. Who should do this? And then the target site versus a surrogate site. So if we try to distinguish those, target sites are defined as sites where you're symptomatic. So heart, kidney, liver, GI tract, and peripheral nerve, for the most part, are our target sites. Surrogate sites are frequently involved with amyloidosis, but you're typically asymptomatic. And the concept is that they're easily accessible or less invasive than a target organ biopsy. So we have a plethora of them. I did not list them all. Fat pad, bone marrow, skin, rectal, GI tract, et cetera. And some of these sites, like the GI tract, could be symptomatic or it could be asymptomatic. But things to think about is this flexor tenosynovium, the ligaments in the lower spine, et cetera, from that perspective. And we'll come back to that in a second. For pad sampling, you saw some pictures today. You can do an aspirate if it's validated, skin punch biopsy, or surgical biopsy. The most important thing is you need a validated technique. So you need to know how this process is from your hands all the way to the lab to reporting, and you should know how effective your reporting is. So to give you an example, at University Health Network, we tried to do an aspirate for a year, and we looked at our sensitivity specificity. It was very low, so we stopped doing it. There could have been a lot of failures in the whole chain of getting it to the lab. So I do a surgical fat pad biopsy. That is the most prevalent in the literature, but people have validated all of them. So Vaishali is fully aspirate. Ray, who's on the call, they do aspirates. They have validated techniques. She's even offered to teach us how to get there. So you need to know your lab. You need to know this. And I think for some of our community partners, they may be hard because no one's seeing this frequently. So actually no one knows the answer to that question. So it does, I think in my mind, bring from a pathology side, should these samples go to reference centers because they're small samples, they're so vital for us to figure out what's going on versus finishing off the whole tissue and not having anything further thereafter. The dialogue between immunohistochemistry and mass spectrometry based on the amount of tissue. So those are important parts that everyone who's in this chain needs to consider in what they're doing. So this is the most important side here. So if you look at the studies and you look at the sensitivity of the different biopsies for light chain amyloidosis. So we get a lot of people who come to us to say, I think this person has amyloid. And we what we have in our hand is we can do a bone marrow. I appreciate that technically doing a bone marrow is in the expertise of the hematologist, but the sensitivity range is 45 to 64, it's 55%. So hit and miss, 50-50 we're gonna get it. And here, if our governing statement is time is of the essence, this is not gonna be enough. So waiting for me to get to consultation to do a bone marrow is part of the puzzle. And the ask of the learning here is if we look at FAT-PAD, it's 76.6% sensitivity, and FAT-PAD plus bone marrow together is about 89%. And so if you're thinking that this person needs a hematological assessment because they have a paraprotein, you need to knee-jerk, no matter what discipline we are, order the FAT-PAD and send to the hematologist at the same time. So we're not delaying things. These two things have to be done concurrently. Bone marrow is not going to give it to you. If we go to the other side and we look at targeted biopsies, kidney and heart works very well, around 90-95% there. GI less so, at around 66%. Liver, yes, there are technical issues, safety issues, about 87%. The skin here is from a neurologist perspective, so it's for epidermal nerve fiber testing. So whether it's skin or it's peripheral nerve, it's a lower sensitivity. And the literature was more limited here to be able to do the skin punch for epidermal nerve fiber density. That's not in everyone's hands. It's specialized labs that do it. It has a lot of processing issues, so it's quite challenging to do. So I think from a neurologist standpoint, paraprotein, axonal neuropathy, worried about amyloid, bone marrow and FAT-PAD would be the direction to go. GI tract, biopsying the GI tract is fine. Liver has some safety issues with it as well, so you're going to have to decide. But the main thing is that the FAT-PAD and the bone marrow needs to be done and thought of at the same time. So the concept of avoiding organ biopsy, so we're very worried about the safety of doing an organ biopsy, and we'll talk about that in a second as well. But this is a study looking at where organ biopsies were done, FAT-PAD and bone marrow were done as well. And you'll see here that if we look at the heart, the kidney, the liver, the nerves a bit lower, about 75% of the time there's a correlate between the organ you biopsied and going for the bone marrow and the FAT-PAD. So again, this is a pathway you can go. You can avoid an organ biopsy, but you need to know your process, you need to know how quickly you can get it done. You know that your lab can handle all of this because time is of the essence for these patients. So these are the recommendations. The strength of the recommendations is what the literature is at this time. And yes, there's a lot of research questions. Yes, there's a lot we need to do as a community to refine all of this. But in patients who you clinically suspect multi-organ light chain amyloidosis, the panel suggests starting with surrogate biopsies first, which is a mandatory combination of FAT-PAD sampling and bone marrow, over doing a target organ biopsy if they can be performed in an expeditious manner. If you know that you can't do that and your endomyocardial biopsy or renal biopsy is more feasible than doing this, then go because of a timing issue and biopsy one of those two organs. From a perspective of a renal amyloidosis perspective, so someone you suspect having light chain amyloidosis from a renal perspective and positivity in the immunological assays, we recommend suggesting performing both abdominal FAT-PAD sampling and bone marrow biopsy over a renal biopsy. And the reason for that is when we looked at this from a safety perspective, renal complications are up to 10% with significant bleeding or further intervention thereafter in this patient population. So we're not saying don't do it. If all things are equal, then go for that as long as you know that you can get it done quickly. Sometimes all things aren't equal, and amyloidosis is only in the differential diagnosis, and other conditions need to be considered. Obviously, in that scenario with interdisciplinary discussion, you would go for a renal biopsy. From a cardiac perspective, in patients that you suspect have light chain amyloidosis of the heart, abnormal cardiac biomarkers, diagnostic echocardiogram, and positivity in any of these studies, we are super interested in making a quick diagnosis. The last talk, Vaishali and Chris both showed us the curves of the stage 3B patients. We're trying to avoid the hematologist meeting the patient who has stage 3B disease 3 months into their diagnosis, where death becomes a significant concern. So here the guidelines recommended started either with fat pad sampling and bone marrow biopsy or with an endomyocardial biopsy. Appreciate that the strength, it's low certainty, but the clinical prioritization here, the panel felt that this was really important in this situation. In terms of safety here, when we did the review, for a cardiac perforation is probably not more than 1 to 2%. There's plausibility, there's a lot of literature from the other cardiac perspective, and I know we have cardiologists in the room who can comment at the end. Usually with a thickened heart, there's less chances of perforation, and most patients with amyloid will have a thickened heart. We couldn't find any specific literature saying that, so that's another research area for us to see what the true complication rate is in a light chain amyloidosis perspective, having a heart biopsy. But if we extrapolate from other cardiomyopathies, that's definitely something that we can consider. So you've done your tissue diagnosis of the affected organ. To prove amyloid, you have to have Congo red staining, so that again, it requires the right testing, the right standards in the lab, usually should be well done, but the CAP, which is the Canadian Association of Pathologists, about 1 year before we are launching our guidelines, they finished standards for the pathologist on the whole processing and evaluation of an amyloid. So you can direct there to have a look at. Apple green birefringence, I hear a variety from pathologists. Some centers will have one pathologist who read for apple green birefringence because it is technically challenging. It is rarely like the picture that I show. It can be quite scant in nature. So again, that expertise within the lab where one person looks at no matter what the tissue origin in versus everyone's comfortable. Fibrillary deposits on EM can be helpful as well, but not all tissues are enough and go in that direction. You must subtype the patient in current times. I think we had a lot of clinical pearls around this today. So immunohistochemical staining on the tissue, I personally find in my lab it works well from a kidney perspective. Immunogold, certain centers in the world have been doing, and mass spectrometry with laser dissection is the gold standard and probably moving in that direction. So just to give you our data, we've been doing mass spectrometry at UHN and providing this service for several years now, almost 5 years. We accept cases from all the provinces in Canada. So there's just a pitch out that if you as clinicians are struggling, Dr. Kulasingham is definitely happy to do it. Yes, there has to be a funding structure, but she will do it for you. So take her contact information. And if you reach out to me, I can even give you the form, etc. from that perspective. Maybe we'll make my email available. And in our last year, majority of cases we picked up was AL, but a good smattering of ATTR, AA, and then unusual subtypes. And to let you know the limitation, we had about a 4% to 5% rate that we were not able to subtype. So whether that's the quality in the machine, understanding, or the scant amount of tissue, it may be a variety of reasons there, but that's sort of what it is. And I think we're the largest center in Canada. I don't know how many centers are doing mass spectrometry, so please do send the samples, okay? These are important good practice statements that we felt would be valuable for everyone to know. We talked about the technique around fat pad sampling. Choose the one that's validated and you know will give you your answer. In patients with proven amyloid deposits on histology, mandatory subtyping in a validated fashion. Again, that's a discussion with your pathologist. With patients highly suspected of having AL amyloidosis with absence of deposits in fat pad and bone marrow biopsies, do not just repeat the same thing again. Go straight to a target biopsy. We could find no literature saying me doing another bone marrow and a plastic surgeon doing another fat pad the second time around is going to help the situation. So it stops there. It must go to an organ biopsy. And I still see there's still a reluctance to go in that pathway, so we're hoping we can push in that direction. And I think a clinical pearl that a lot of people recognized was in patients with light chain amyloidosis, you may have valuable historical samples, right? Carpal tunnel release, prostate biopsy, bladder biopsy, get them tested, get Congo red done. We thought pragmatically if it's within the last 3 years, because it's on site, so it's quick, And two, if we look at the prodrome of clinical symptoms to making a diagnosis of amyloid being a maximum 3 years, this may be able to quickly stop you in a pathway towards biopsy because you got it from a historical sample. So make sure you think of that, look for it, and order the Congo Red, and then send it for subtyping thereafter. Okay? So putting it all together, we have amyloid-related symptoms, we have evidence of Congo Red deposits in the tissue, we have mandatory subtyping to figure out that this is light chain amyloidosis, and we talked about a starting point of all 3 immunological assays: serum, urine, electrophoresis, and immunofixation, and the free light chain assays. Remember the caveat, I think it was said earlier, be careful with the free light chain assay interpretation by age and renal dysfunction. There are some guidelines for that to have a look at. Okay, last part before we're ready to treat would be you need to do an evaluation. The bone marrow needs to get done nonetheless. Cytogenetics in the bone marrow, most centers are doing. Look for organ involvement with the appropriate testing. I think there's a growing use of cardiac MRI, which we recognized in one of our guidelines as well. And we were very particular in our guidelines in the use of PYP scans. So in patients who have no paraproteins, highly recommended to do a PYP scan. That is a very validated pathway. But in patients who have a paraprotein, our official guidelines are do not do a PYP scan. It will not help you make a timely, effective diagnosis of light chain amyloidosis. Okay? Then to finish off here, we're really focusing on amyloid awareness, recognizing those early symptoms, and then diagnosis, timely and effective. But I think I've highlighted to you, you need multidisciplinary care and communication. You need those built pathways all the way to the pathologist at the end. And you need to start looking at metrics to say, how quickly are you doing all of this? So with this compendium of work, ASH will be releasing dissemination products, but also be releasing some quality metrics to consider that each site can have a look at and consider doing. So I'll stop there. These are learnings over the last few years. And again, I'm going to thank the 30 people who were with me doing this journey. It was a lot of work, but I think highly valuable, recognizing that the literature still has a lot to go.
Thank you. Thank you, Dr. Cucretti. That was a fantastic overview, and congratulations to you and your colleagues for the tremendous amount of work that you've done, and really excited to read the finished product. That
so
is
am I.
a tremendous accomplishment, really. So I think maybe just what we'll do is for this session, we'll maybe reserve questions for now. And maybe why don't you stay up here, actually, because then we can have some questions to you after. And we'll go to Dr. Comenzo and his presentation. So yeah, hi, we can see you now, Dr. Comenzo. Welcome, and I know you've been on the line for a little while, but thanks very much for joining us. And Dr. Comenzo, of course, is yet another kind of luminary, internationally recognized figure who's been a great friend and supporter of our Canadian amyloidosis community. So it's a pleasure to see you again virtually, and thanks very much for being here. And yeah, we look forward to your presentation.
Thank you very much. I definitely would like to thank the organizers for having me. I suppose I should shut my speakers off. Let's do that. Yeah, so I'd like the organizers for inviting me, and I'm particularly honored to be on the same list of speakers with Dr. Vena, Dr. Sanchurwala, and Dr. Cucretti. And I must say, Dr. Cucretti led a fabulous group of us as we worked robustly, was his term, to put the guidelines together. My sense of it was that at times it was sort of like running into your oncologist in the supermarket. It was really a challenging process. I would like to be able to share my slides if I can. Let's see. Post attendee Zoom. Email, whiteboard, what is this, screen? Um, yeah. So I don't know why my PowerPoint is not sharing. It's definitely up there. Um, yeah, so
Quest team, do we
let's
have
see. We
any,
can try it
can we
again.
help Dr. Comenzo, or is it just he's got to share?
Share screen.
Yeah, okay.
Uh, I don't know why it's show
Okay.
all windows. Sure, show all windows.
Dr.
I'm all
Comenzo,
for that.
we, we,
Um,
we have the PDF version of your presentation, if you're
oh,
having.
here we go. Got it.
Oh, okay, good.
All right.
Oh, yeah, now we see it.
So um, the characteristic of clinical research in light chain amyloid has been frequent failure. Looking back on the trials that Vishali described, it was a remarkable experience to do a phase 2 investigator-initiated trial and to have the application of stem cell transplant taken up by CMS, the Medicare portion of the government, in just a matter of years. And that made a huge difference for patients. We're in a completely different ballpark now, unfortunately. And I think that the failure of the tourmaline trial and the failure of 3 AL depleter trials is going to have a huge impact, particularly on the pharmaceutical industry. These are my disclosures, and this is the outline of what I'm going to be talking about. I'm going to be really emphasizing the concept of heterogeneity. And I'm going to be challenging the concept that amyloid fibrils are the primary cause of amyloidosis, the disease. I'm going to be talking a little bit about the sweet spot for drug development, and I'm going to be talking a fair amount about the 3 approaches to depletion that were engineered by 3 huge figures, Mark Pepys, Dale Schenk, and Alan Solomon. And I'm going to be talking about the lessons learned. The image on the right highlights the fact that pharmaceutical drug development is a casino, and at times it's fairly crazy, and it involves the willingness to gamble large amounts of money. But if you just want to leave now, I did ask Gemini, why did dazimizumab and salamimab and bertamimab fail? And we were told by Gemini that they failed because they did not show the expected clinical benefits. We don't know how much money GSK put on the table for Pepe's approach, but we know that it was tens of millions, if not hundreds of millions of dollars, because there was a significant component of hospitalization required. Alexion and AstraZeneca's investment in KL-101 or anselamimab was probably up to $400 or $500 million. And it's unclear to me where things will go from here with that molecule. The Prothena experience, interesting experience. We also had a trial that was stopped, which I'll talk a little bit about. But this experience was unique because Prothena got 2 bites of the apple. The phase 3 VITAL trial was closed in April of 2018 because of futility. A futility analysis was done shortly after, I think it was Bristol Myers bought Prothena. However, the agency, the FDA, was very sympathetic to the data that was provided by Prothena with respect to the stage 4 AL cases. And the FDA designed a really, really favorable trial, AFFIRM, which also failed to meet its clinical endpoints. So these are amyloid fibrils. These fibrils were derived from the heart of a man who had amyloid for about 8 years, but died of metastatic bladder cancer. And as you can see, they have a particular morphologic appearance. The globules around the fibrils are fat globules. And this is what we see when we do a tissue biopsy, the apple green birefringence. This is a glomerulus and a small arteriole below it. And, you know, it's a terrible stain. It's a terrible biopsy process. Vishal explained their experience and the fact that they had to go to fat pad biopsies, surgical biopsies. And I think that it's a burden that we face. And the fact that these fat pads turn positive late in the course of disease is an important thing to keep in mind. This is the disease. It's a multi-system disease. It involves the heart, obviously, the kidneys, the liver, the ligaments of the soft tissue, the peripheral autonomic nervous system. And the findings that Vishali alluded to, the raccoon eyes are shown in the image at the top. And that image actually, I think, is from a paper we published in the New England Journal 30 years ago. A major advance has been the availability of mass spec, and I applaud Vishal's work in this area for your country. Mass spec really taught us that the deposits of amyloid in tissue are multiomic. There are multiple proteins in the deposits. There are numerous apolipoproteins. There are hemoglobin molecules, and there are complement molecules. So these are complex deposits that always, if positive, contain or usually contain 95% of the time the culprit protein, whether it's a kappa light chain or a lambda light chain. Usually they can pick up the variable region as well as the constant region of both of those light chains. So it's really, really important to understand that this diagnostic approach has made a tremendous difference in our ability to conduct clinical trials, particularly, but also to help patients. But the point here today is that there are layers upon layers of heterogeneity. And one of the layers Chris alluded to, and that is the activity of Daracibord-D designing a clinical trial for newly diagnosed patients and trying to test a depleter. I agree with that. I agree that that contributed to the failure of the clinical trials, except for the PEPI's trial, which really focused on patients with amyloid that was active. One trial that I'll describe in some detail later in the development of the PEPI's approach did look at patients with cardiac AL, but there were also patients who've been treated with conventional chemotherapy. The heterogeneity in the study populations is really well described. The delays in diagnosis, the differences in the stages, the fact that we still experience a significant fraction of patients who die early. We don't have good ways of measuring the amount of amyloid in a patient or of characterizing the deposits, but that, in all likelihood, is also a component of heterogeneity. And the organ microenvironments. I think a substantial argument can be made that we know very little about the microenvironments. I'm going to speak very briefly about the marrow microenvironment and the renal microenvironment, but this is an area where our knowledge is really limited. We do know that the immune system does respond, but that the response is overall muted, which is another aspect of the microenvironmental response that's likely heterogeneous. Vishali mentioned the composite endpoint of major organ deterioration, progression-free survival, very important composite endpoint, and it combines both organ-related and hematologic features of the disease in order to give clinical trial research a valid approach to the impact of amyloidosis, the disease. I do agree with Chris that the relapse population is different. I'm not sure what the best endpoint is, but we are burdened today because there's no standard therapy, and therefore you can't design a phase 3 trial effectively. And the BCMA-directed therapies are going to struggle to get approval for AL, which is why Chris's strategy and your strategy of looking for those areas of the marrow biopsy which have 10% plasma cells or more, the areas of the marrow biopsy that clearly define a clonal hematologic disease are very important for indicating that the patient has quote unquote multiple myeloma. It's a strategy we also follow. The delays in diagnosis have been described both by Vishal and by Vaishali, and it remains a problem. It remains a problem that we see the historical aspects of in the medical records of individuals who've seen cardiologists 20 times a year for the past 3 years until a young cardiologist comes on the scene that sends the light chain test. And by that time, it's probably too late to help the patient. Another major advance is due to Joe Bradwell, who is a similar figure to Lord Challenger in the, I think it's H.G. Wells' article, Lost World, book, Lost World. The free light chain assay is very important not only for myeloma because clones can undergo light chain escape. It's particularly important for light chain amyloid for the purpose that Chris described, and that is that it is indeed the vector of disease. The gold diamonds are individual measurements of amyloid light chain levels, and you can see that the lambda levels are present 3 to 1 to the kappa levels. We do use these abbreviations: involved free light chain, which is one thing, and DFLC, which is the involved minus the uninvolved light chain. There is an asymptomatic precursor phase, which can go back 10 years, thanks to the work of Brendan Weiss, who evaluated the annual serum samples that were preserved in the Department of Defense biorepository. And what he saw was that at the time of diagnosis, over half of the patients had cardiac symptoms and involvement. And therefore, it became very important to think of ways you could screen patients to diagnose the disease earlier. And I agree with everything Vaishali described. We've been dealing with this problem for 10 years. And one of the things that was a springboard for us was the fact that the germline gene use of variable region germline genes in AL is restricted. And this is the work of Gareth Morgan at BU, who really went through thousands of sequences and determined that there were 16 germline genes enriched in light chain amyloid, 12 lambda and 4 kappa. And we've used most of those lambda genes initially in 2 clinical studies and are now using all kappa as well as lambda genes that are enriched in AL in our current national study. So this is the first study we did starting in 2014, I think. It was internet-based. We talked to patients on the phone. We got consent over the phone and by fax. And patients had to be patients with a lambda gammopathy, smoldering myeloma or MGUS. They had to send us peripheral blood, and from peripheral blood, we could identify the variable region light chain genes. And also they had to have a DFLC greater than 23 based on Brendan Weiss's work. We identified 2 cases of amyloid of 21 patients. The 2 both had smoldering myeloma. So 2 of 19 smolderers in this study were identified, treated, and are in complete remissions to this day. And I got confirmation from a colleague in Italy about the patient from Illinois who's still in a CR and doing very well. The patient in North Carolina also is in a CR doing very well. That patient was on the Andromeda study. So 2 of 19 smolderers. Then we were able to get a limited amount of funding to do a limited multi-center trial. There were 6 centers in this trial. We decided to restrict the age a bit, and we continued to use the DFLC greater than 23 in an abnormal ratio, no prior biopsies with amyloid. And we also recorded the presence of the 1114 translocation in GAIN1Q based on CD138 FISH. Vishali mentioned those too, but about 75% of patients with AL have the 1114 and GAIN1Q. It works out to be about 50 and 25, 50% with the 1114 and 25 with GAIN1Q. And we also segregated based on AL-related light chain variable regions. And we did a clinical evaluation on those 22 cases. 3 of them had AL of 10 smolderers, and none of the 12 MGUS patients had AL. And the other 8 were attended to based on the standard of care. And I'll tell you a little bit about what happened to them shortly. And the table on the right is simply a list of the variable region genes, all of which we recorded in GeneBank. The other thing about this trial was that we wanted to demonstrate that we could amplify the variable region gene from bone marrow mononuclear cells, and that CD138 selection was not needed. We were very effective in this, and we were able to get the Columbia University Medical Center Precision Medicine Lab, led by Mahesh Mansukhani, involved in this. They were able to use the cDNA we sent them to identify the variable region genes on the Illumina platform. So we're in the process of developing a laboratory-developed test at Columbia. So in those 2 initial studies, we picked up 5 AL cases and 36 smolderers, no AL and 15 MGUS cases. There were 8 patients with smoldering who progressed, 7 to myeloma requiring therapy and 1 to a glioblastoma. We were impressed that in the SAVE-2 trial, the presence of an AL gene, 1114 or GAIN1Q, were found in 6 smolderers, including the 3 we identified in that trial. The 3 were individuals from California, UCSF, a woman in her 70s who had cardiac amyloid, was treated, achieved a PR with organ improvement. A man in Tennessee with neuropathic disease who was treated, achieved a CR, and a man in New York who had cardiac involvement who was treated and achieved a CR as well. All 3 are alive and well. So the rest of this slide describes the frequency with which smolderers have the 1114 or GAIN1Q. And as you can see, it's about 50% in smolderers, and it's about 70, 75, maybe even a little higher in AL cases. Now, these data allowed us to apply for a large multi-center trial, which is funded and ongoing now. And these are the centers that are involved. I really appreciate their involvement. We're getting samples of marrow and blood, anywhere from 3 to 8 samples a week. It's been a challenge to open the trial over the past 18 months that it's been open. It's been a challenge because of the shortage of personnel in healthcare and the turnover in clinical trials offices. But we've been very blessed to have the involvement of these investigators. And as of, let's see, whatever this is, I think it's September 1, um, the trial has accrued 36 smolderers and 25 MGUS cases. The MGUS cases are in a different category. I suspect by the first of the year, we'll have somewhere between 80 and 100 smolderers. And we're on track to really meet the accrual goals that we've set for this study. The variables that we're evaluating as part of the creation of an algorithm for screening patients with smoldering myeloma are the presence of smoldering myeloma, the two cytogenetic abnormalities, the variable region light chain germline gene that's present, also the NT-proBNP level greater than 332. So we really believe that we'll be able to come up with an algorithm which folks will be able to punch standard findings into to get a risk profile in a smoldering myeloma patient. We have identified several patients with amyloid, including one case where the patient had uh, a light chain findings, as well as the presence of smoldering myeloma, uh, and had to undergo a heart biopsy because of age. And that patient turned out to have TTR amyloid. So the algorithm for screening in smoldering myeloma did pick up one case of TTR. So the staging systems are important, particularly for prognosis. This is the original cardiac staging system on the left and the original renal staging system on the right. And then the 2012 staging system developed by Shaji Kumar, which included not only the NT-pro, but also the light chain level. So my point here is that the staging systems are dynamic over time and have been changed and adjusted and improved, and we'll hear at ASH about another improvement. However, we still see early mortality. Patients with AL are still diagnosed with advanced disease and die. And we know there's heterogeneity in the basic data of patients at diagnosis in terms of organ involvement, cardiac stage, the light chains that are used, as well as the variable region gene utilization and the light chain levels themselves. And we know, as I said, that the variable region gene use is restricted in AL. What's also interesting, and this is an immunoblot of light chains. Lane 1 is the plasma from the bone marrow of the patient. Lane 2 is the supernatant from a CHO cell line, which expresses the same gene. We're able to transduce CHO cells to produce AL light chain genes. And the third and fourth lanes are from mice into which those CHO cells have been xenografted. And the important point of the blot is look at all of the aggregates. You can see the monomer, you can see the dimer, but look at the larger aggregates here. And it's those aggregates that play a role, actually, in the process of light chain misfolding. This is what one of the mouse's kidneys look like. You can see the amyloid in the tubules, and you can see in these images the possibility that there's amyloid in the tissue here. This is an area of very active work in our lab, as you can imagine. But the important thing is that the light chains do distribute to the organs in our mouse model. And this is a very important slide from the work of Dr. Buchner, a German amyloid researcher. If you look at the upper left-hand corner, you'll see the legend. The gray bars, monomers and dimers, the little blue bars, oligomers, and the purple bars, fibrils. And what he's described is the process of fibril formation, which we know has a long lag time based on Brendan Weiss's work. So what happens early on is that a monomer partially opens, and then an oligomer that contains partially opened monomers allows those and enables those monomers, those misfolded monomers, to undergo a rearrangement. And what happens is the monomer flips around the intrachain disulfide bond and flattens out. And the sticky residues, the sticky amino acids on the surface of that flipped monomer allow the assembly of fibrils as monomers self-assemble and form fibrils. And this takes quite a while. And this is the product. This is the bone marrow of a patient who's got amyloid fibrils and deposits in the bone marrow. And, you know, there's no rhyme or reason to the appearance, but under electron microscopy, we do see some variously different patterns. So Giada Bianchi and I pooled a series of bone marrow studies using single-cell RNA-seq, which is not a spatial technique, but rather a technique that studies gene expression in the different lineages in the bone marrow. And this is ongoing work in multiple labs. And as you can see in the image at the top, the H&E, the CD138 showing the plasma cells, the Congo red stain showing amyloid and under polarized light. What we've learned, and we were really surprised to see this, was that the CD34 pool of stem cells is decreased in marrows that have light chain amyloid in them, as opposed to marrows that do not have deposits in them. That the phagocytic populations are altered somewhat numerically and phenotypically and are sort of put to sleep in the marrows that have amyloid in them. And that patients with light chain amyloid show changes in both malignant plasma cell enrichment and a newly defined normal plasma cell subset, which Giada has gone into detail to describe in the recent Blood manuscript. And that an inflammatory transcriptional signature is present in the bone marrow microenvironment in light chain amyloidosis compared to normals. Giada had a series of normals whom she was able to characterize. And it's important to note that we've seen the same thing in a prior study. This was the study that Chris hoped could be done. We initiated this study about 8 years ago with the folks from Prothena, and the design of the trial is previously treated AL patients with hematologic responses and persistent renal involvement. And they had to have at least 6 months from prior chemotherapy and 12 months from stem cell transplant. They all had to have renal biopsies as part of the screening process. And the renal biopsies, as I'll explain, were studied very carefully. Patients were randomized to NEOD-001, which is pertemamab or placebo. And unfortunately, this trial was also stopped on April 18th, 2018, April 23rd, 2018, when the first halt was imposed by Prothena on the development of pertemamab. But we had enrolled 10 patients and we were able to get data from those patients. The data was published in Kidney International in February of last year. And we also had wonderful pathologists, Agnes Fogo from Vanderbilt and Sami Nasser from Mayo, who helped tremendously to review the biopsies. We had great clinical research associates who were able to get the biopsies available to the pathologists and maintain the data that was developed. And as you can see, there was heterogeneity in the amyloid score. There was heterogeneity in the composite injury score as well. This is very, very important because we're able to correlate these findings with the bulk transcriptional data generated by the Neptune program at the University of Michigan under the direction of Matthias Kretzler. And there was significant inter-observer agreement with respect to this scoring process, very important. And we were tremendously benefited from the expertise at the University of Michigan and Matthias's group. Basically, they would separate out the tubular and the glomerular cells, and they were able to do individual transcriptional profiles of those components. These are the 9 patients we ended up on the study, and some had a renal response to the treatment, some did not. But I can tell you that I believe it was, the first patient on the trial actually ended up having a decrease in proteinuria some months after the trial stopped. And he had been under 500 milligrams a day of proteinuria with maintained renal function until about 2 months ago when his light chain started to go up again. And I will actually be seeing him next Thursday. And this is his data depicted here. He was on RAIN receiving NEOD during that boxed-in period, and subsequently over years, his proteinuria declined. And his plasma cell disease had been well controlled by the stem cell transplant. He's had no subsequent therapy since his stem cell transplant, which was, let's see, actually had 1 cycle of Exasmid Dex consolidation. Yeah, that's right. So in 2016, he had his MEL200 transplant. So the MEL200 and the cycle of Exasmid Dex actually has kept him in good shape until recently. So the transcriptional profiling work was very interesting. He also used the Illumina platform, did hierarchical cluster analysis and pathway analysis, and compared the findings to individuals whose kidneys were normal or individuals who had focal segmental glomerulosclerosis. And he and his team had, I think, dealt with about somewhere around 800 kidney biopsies of different renal diagnoses at the time he did this work. And ironically, they were able to identify 2 different clusters. And the amyloid score was significantly higher in the G2 cluster. Little box there on the left is where that patient I mentioned, patient number 1 was, versus G1 in the tubular compartment. The increase in the amyloid score in G2 was driven almost entirely by an increase in angio, and importantly, capillary wall amyloid deposition. So there were a series of different pathways and genes which were highlighted by this work, despite the fact that the sample size is small. But the inflammatory cytokines that were upregulated included TNF, IL-33, IL-15, IL-8, and the PI3 kinase AKT pathway was also upregulated. And these were the findings that Kidney International reports highlighted: 2 distinct gene expression-based patient clusters, fibrotic pathway activation in the glomeruli, et cetera, et cetera. So the heterogeneity of study populations is present on many layers, many levels. And the staging dynamics are important too, because stages are used for stratification. We have better diagnostic tools now, and GLS will be incorporated into the staging system in a presentation at ASH. We have better anti-plasma cell therapies, outcomes are changing, and the staging systems have been revised in numerous ways. And this has an impact not only on the thresholds and endpoints of potential clinical research, but also on study populations that can be incorporated. Post-treatment outcomes are also important to keep in mind. And over time, patients who have renal involvement can develop end-stage renal disease very slowly. At the same time, we know that the body in patients who have complete hematologic responses can resorb amyloid. And this is a set of images from 30 plus years ago in a patient who achieved a complete response after stem cell transplant. Currently, that patient is alive and well at this point in time with no evidence of recurrence. So maybe there's going to be a way for us to appreciate the amyloid load. And I think that way is going to be, uh, excuse me, that way is going to be imaging. And I do want to mention imaging. This is the work of Shamila Dobala. And as you can see, liver, heart, thyroid gland, kidneys can be appreciated with beta-peer imaging. And there are other imaging agents. One that's particularly interesting is evozametide. These are radio-labeled imaging tools, and that complicates things because radio labeling results in proteins that have limited half-life. But it's very important to keep in mind that this kind of an approach will give us a measure of amyloid burden. And what Shamila has shown is that individual patients with AL who do not have PET positivity do much better than patients who do have PET positivity with respect to survival. So let's talk about these three depleters. These depleters represent a lifetime in each case of scientific effort. Mark Pepys studied serum amyloid P component in a variety of different types of amyloid. And he developed an approach designed to deplete amyloid. First step was using a compound called CPHPC, which cleared serum amyloid P component from the blood. Now, serum amyloid P component is part of the contraction thing, and it's actually a sandwich. And what CPHPC did was it forced the SAP to form a different type of sandwich that was cleared in the liver. So he was able to markedly reduce the SAP circulating. Now, SAP protects amyloid fibrils from proteolysis. And despite the fact that he cleared it from the blood, there was still enough SAP in the amyloid deposits for his antibodies, desimizumab antibodies, to bind to SAP and to activate phagocytosis and clear the amyloid. So 2000, I think it was 2010 maybe, a manuscript in New England Journal showed images of amyloid being depleted, of SAA being depleted, of CRP being present, and C3 being depleted as well, and amyloid being removed from the liver. None of these individuals had AL. They all had different types of amyloid other than AL. So then they went on to do a study in patients with cardiac amyloid. It was an open label phase 2 study, and they did PET imaging as well in these cases. They used the immuno-PET study to measure cardiac uptake of the anti-SAP antibody, desimizumab. And uptake was low, moderate to low. And uptake was notably lower in an AL patient who had high left ventricular mass. In the AL patients on the study, they had side effects. One had a small vessel vasculitis, and one had large vessel vasculitis after initial exposure to desimizumab. Even though steroids helped, the patient with large vessel vasculitis took a while to resolve. And at that point, GSK dropped development of this approach. And this is an image of amyloid in a blood vessel. The blood vessel becomes distorted. And I think it's important to keep in mind that in AL amyloid, one of the reasons that we do fat pad aspirates is because if there are blood vessels in the fat, they contain amyloid and stain positive by Congo red. And therefore, the vasculature is significantly involved in light chain amyloid. Now, the next one was the bertemimab story, and it involved a brilliant fellow named Dale Schenk, who started out as a Alzheimer's doctor. And he developed an antibody, AN 1792, that was able to bind a beta amyloid in the mouse. And it led to an immunization trial in humans. And what occurred in the 6% of participants was, as you can see in the CT image, vasogenic edema. It was a severe inflammatory reaction. And post-mortem analysis showed that it worked. It cleared amyloid in those areas, but the antibodies bound to amyloid in the vessels, triggering inflammation and activation of immune cells. So this is quite a story historically in immune-mediated therapies, that the ones that actually work cause significant immune-related side effects, often inflammatory. Well, that molecule was purchased from the company Elan by a consortium of 3 other companies for a significant amount of money. And Dale was given a huge pot of money by Elan to do what he wanted to do, and he wanted to develop a therapy for light chain amyloid. And he worked with Jonathan Wall at the University of Tennessee, and they identified a monoclonal antibody 2A4 that was originally targeting serum amyloid protein A, and also had reactivity with immunoglobulin light chain amyloid fibrils. So they decided to bring this forward into the clinic. And early on, the results were really impressive. And the biomarkers that we used for cardiac involvement showed evidence of improvement. Proteinuria went down in some patients. And the use of bertemimab in the phase 3 VITAL trial was very exciting for us, because we thought we might be able to help patients get better fast and survive. Well, the phase 3 VITAL trial did not meet its endpoint, but as the graph in the upper left-hand part of the screen shows, there was an apparent benefit in patients with stage 4 amyloid, elevated light chains, elevated NT-proBNP. They did not track survival beyond 9 months, but they had enough data to convince the FDA to help them design and conduct a new trial just focused on those patients who were stage 4. And that trial was called AFFIRM. And it was another way to test, as the sketch on the right side shows, the activity of bertemimab against these soluble amyloid aggregates and against fibrils. They really anticipated that they were going to be able to have activity in these cases where the amyloid burden was high based on the light chain level and the NT-proBNP. However, the AFFIRM trial failed. And there were no side effects here, just as there were no side effects in the earlier versions involving the use of bertemimab. And then there's anselamimab, which is KEL-101, the most recent failure. It was the product of Dr. Solomon's lab, again, a life's work. Now, as you can see in this cover of Blood from 15 years ago, radio-labeled anselamimab actually was taken up in areas where there was amyloid. It was not taken up in the heart, but it was taken up in the liver and the bone marrow, for sure, as you can see in the image. And that was a very exciting opportunity for amyloid doctors. And Suzanne Lench at Columbia developed the use of KAL-101 in AL in a phase 1 trial, which showed some suggestion of benefit. And then the CARES trials for patients with 3A or 3B cardiac amyloid were started, and the endpoint was overall survival or reducing cardiovascular hospitalizations. However, the large trial combining those two stages of light chain amyloid heart involvement did not meet the primary endpoint. The antibody didn't work. They claimed that a pre-specified subgroup analysis showed a meaningful clinical benefit in some cases. We're awaiting that data. There were no side effects to the drug. So unlike the PEPI's combination, it wasn't side effects that scotched both birtamimab and anselamimab. And I think it's important to understand the point that William Powell makes in his recent book, Breakthrough, a wonderful book, which I encourage you to buy and read. And that is that there's a sweet spot for drug development. And it involves the biological understanding of the target, the clinical understanding of the disease, and technical advances. And I believe that we have a limited biological understanding of the deposits themselves and the microenvironment that is affected by the deposits. Light chain behavior, we have a limited appreciation of the distribution of those misfolded monomers that are impacted by the aggregates that circulate. We have a limited understanding of what actually happens to the fibrils in the deposits, what the turnover is, and how those fibrils may be shielded not only by SAP, but also by the various lipids that are present in the deposits. And we really have a limited understanding of what these variant light chain monomers that circulate and are products in part of their experience in aggregates that we don't really know a lot about, and what they do in the deposits, how they support the continuation of fibril formation. The impact on epitope availability can be considered, but we know that SAP was available in the PEPI's model. And the question that arises is that the circulation of light chains has an effect. And we talk about toxic oligomers. The data on toxic oligomers is really kind of slim. But are there previvor, survivor, and apoptotic cascades in the microenvironment that can affect the level of thickness the patient has, as well as the progress towards improvement or towards organ failure? And the behavior of the therapeutic antibodies. We know that the anti-SAP antibody was not taken up very effectively by the heart. And was that the case with anselamimab and birtamimab? We don't know. And we do know that the monocyte macrophage activation component, based on our assessment of what happens in bone marrows with light chain amyloid present, is somewhat unusual, and that to some degree, the adaptive immune system is somewhat asleep, but can be activated by the presence of anti-amyloid antibodies. And whether or not that's a good thing or something that would be potentially harmful, as it was in PEPI's trial, is a matter of concern. So the lessons learned. There are layers of heterogeneity, that deposits in organs differ significantly. We know that there was TNF activity in both the kidneys and the marrows that had amyloid in them. We know innate immunity can be active. And the real question is, how much of the damage that we associate with amyloidosis disease is caused by the fibrils and deposits, and how much is caused by the response of the microenvironment and the individual tissues to those deposits? And do organ-specific responses cause disease? We know there are 750 different proteases in the human genome, and some kind of distribution of proteolytic activity may play a role. We do need models of early disease, not terminal disease. The models of early disease to tell us about enucleation and propagation of deposits are sorely needed. And we have to share the hope of others that the road of excess is leading to the palace of wisdom. And we have to hope that there are pharmaceutical companies and investors out there who are still willing to pursue the goal of treating patients with light chain amyloid and improving their quality of life, overall survival, and their maintenance of organ function. And with that, I'd like to thank the funding agencies that have supported our work, and the doctors and nurse practitioners I work with, and the folks in our lab and our core lab PhDs who've helped us. And thank you for your attention.
Okay. Thank you very much, Dr. Comenzo, for that fantastic and very detailed overview and all of your insights and experiences. We're running a bit over time, but I think if we have time for a question. If there's a question for either Dr. Comenzo or Dr. Cucretti, happy to put it forward. Chris, do you have a microphone? Yeah.
Thanks very much, Ray, for that excellent overview. I was wondering what your thoughts are with respect to the risk of vasculitis as a complication that basically any new product coming to the forefront for antifibril therapy should be aware of. Because it's interesting that it was really only a big problem with the anti-SAP molecule. So is that more of a serum sickness kind of phenomenon, and for reasons, as maybe you alluded to, we don't understand, it wasn't an issue for the other ones? Or if we have a robust enough product, is it maybe still a risk?
I honestly don't know. I think I should shut my speakers off again. The fact that it has occurred in Alzheimer's and then again in the anti-SAP may have something specific to do with the type of immune activation that occurred. I agree with you, vasculitis is always a risk for new immunotherapy, but my bias is that we should forget about the amyloid. We should forget about depleting it. We should really study the microenvironment, because I suspect there's a cascade, previvor, survivor, apoptotic cascade that might produce a range of druggable targets, and that with what we have for anti-plasma cell agents, it may not take a lot of effort to quiet the microenvironment and prevent progression of organ damage in that fashion.
Great. Okay. Thanks very much. No other questions? Any other? Okay. Well, I want to thank you again, Dr. Cucretti and Dr. Comenzo, and everyone here. We've had a wonderful day, and tomorrow, starting at 9:30, is day 2, and it'll have kind of a distinctly different flavor. But thanks very much to all our speakers for a fantastic day. And so maybe we can just give one more round of applause for all. And then I just want to mention that at 4:30 we have our first Canadian Amyloidosis Society annual general meeting. So if there are any members here or anyone who's a healthcare provider, really anyone who provides healthcare to amyloidosis patients who would like to be a member, please stick around. It's an important meeting, and I think we're really going to try to set the course over the next year for the society. And so thanks for considering that. We're also going to have a Zoom audience for that meeting as well. But otherwise, we'll wrap up today's activities for the summit. And thanks very much again for coming.